Hello, this is Dr. Chetan Deshmukh from Dinanath Mangeshkar Hospital, Pune, and I'll be discussing two important studies. The first is adjuvant pertuzumab and trastuzumab in early HER2-positive breast cancer, the Affinity trial, a 6-year follow-up presented by Professor Picard et al. In the Lancet Oncology. Just to give you a background, this study was an randomized double-blind study where patients who underwent surgery first and those patients who had node positive disease or a tumor which was more than 1 centimeter or less than a centimeter but with high risk features, these patients were randomized to standard taxane based chemotherapy plus trastuzumab and pertuzumab in the usual recommended doses, or the other group received taxane chemotherapy plus trastuzumab and a placebo. And the primary endpoint was invasive disease-free survival, and the secondary interim analysis was also done to find out a pre-planned, time-driven overall survival analysis after 2.5 years. So the baseline characteristics, patients were reasonably well matched. An interesting finding was more than half of these patients had node positive disease. In fact, there was an amendment after 3,655 patients were randomized, and thereafter only node positive patients were taken up. So more than 50% of population in both the arms had node positive patients. 25% of these patients were with a higher nodal burden. People had more than 4 nodes positive at surgery. 36% of patients in both the arms were ERPR negative and 64% were ERPR positive. The overall survival sadly did not meet the required criteria, and if you can see, there's just one line only at the end at 6 years. You can see a streak of red colored line. The overall survival thus did not show any difference, 94.8 versus 93.9, so almost numerically just about a single percentage difference in both the arms, but possibly the overall survival events were less in number. The invasive disease-free survival again divided into 4 subsets: node positive, node negative, hormone receptor negative, and hormone receptor positive. Here, the node positive subset did better with the addition of pertuzumab over placebo. The difference is numerically about 4%, and the hazard ratio was 0.72. So the 28% reduction in the possibility of having an invasive disease event. In the node negative population, there was hardly any difference. In fact, you can again see almost a straight line, both lines converging one on top of the other. In HR negative or HR positive women, there was not a very great difference. Both the subgroups had an hazard ratio of 0.83. So possibly the node positivity is the one which is driving the benefit for adjuvant pertuzumab. There was no improvement in overall survival after 6 long years of follow-up, but as I said, the number of overall survival events was low. The benefit of adding pertuzumab was most prominent in the node positive subset. So dual anti-HER2 blockade was not recommended in the node negative subset as per this study. There was no difference in the hormone positive or hormone negative subset, and there was no increase in the cardiac events, so no new cardiac safety signal. I feel that there is a definite benefit in the node positive subset. It would be interesting to find out how this group, the one which had more than 4 nodes positive in the armpit, this population did. Remember, there was a sizable population of these type of patients. Both arms had 25% of such patients. The only concern remains cost and benefit. The benefit really seems to be limited in a very limited subgroup, and the humongous cost which involves in administering both trastuzumab and pertuzumab. Right now, we are struggling to get all the eligible patients under the umbrella of trastuzumab. Adding another monoclonal antibody sounds a little difficult, at least at this point of time. The next study is a fixed dose combination of pertuzumab and trastuzumab for subcutaneous injection plus chemotherapy in HER2 positive early breast cancer, a randomized open label multicenter non-inferiority phase 3 study. again published in Lancet Oncology, December 2020. Uh, the idea is interesting. The combination of trastuzumab and pertuzumab has proven itself in the neoadjuvant setting, in the metastatic setting, and now in the adjuvant setting of affinity study as well. Now, both these monoclonal antibodies are given intravenously, and the infusion time ranges from 30 to 90 minutes individually, which requires a long-term IV access. There is increased preparation time, there is increased load on the healthcare system, and increased hospital visits as well. So this study reports primary result of a very novel fixed dose combination of a non-weight based dosing, 600 milligram of both trastuzumab and pertuzumab, which was given subcutaneously. The Federica study design was for patients who were planned for neoadjuvant chemotherapy. Patients had either operable, locally advanced, or inflammatory breast cancer, which were HER2 positive. Tumor was more than 2 centimeter in diameter, or patients had node positive disease with good ECOG performance status and an adequate cardiac function. These patients were given dose dense cyclophosphamide plus doxorubicin for 4 courses, and after that, these patients were randomized to 2 arms. One arm received either docetaxel or dose-dense paclitaxel. This choice was left to the investigator. Docetaxel, dose-dense paclitaxel plus trastuzumab and pertuzumab intravenously, and the other arm received docetaxel or dose-dense paclitaxel with a fixed dose subcutaneous trastuzumab-pertuzumab combination. More or less equal patients, the baseline characteristics were also pretty well matched in both the groups. The primary objective was non-inferiority of the cycle 7 pertuzumab serum C-trough level within the fixed dose combination versus intravenous pertuzumab. So this matched with the pathological CR assessment timing as well. So the result showed that the C-trough level concentration of pertuzumab at the end of cycle 7 was not inferior with the fixed dose combination. The C-trough level with both the intravenous infusion as well as the fixed dose combination was not very different. There was no statistical difference between the two. So that primary endpoint was achieved. The second important thing was the pathological complete response. We know that in HR HER2 positive patients, we are always harping on pathological complete response rate. In both these groups, the pathological complete response rate was same. In the intravenous group, the pathological complete response was 59.5%, and in the fixed dose combination, the pathological complete response was 59.7%. So no difference in the pathological complete response rate. Either you use intravenous trastuzumab, pertuzumab, or you use fixed dose combination. Toxicity wise, the common is grade 3, grade 4 adverse events, which happened in more than 5% or more patients. These were largely related to the chemotherapy which accompanied this combination. So neutropenia, febrile neutropenia, diarrhea, and leukopenia, these were the common side effects. Grade 3, grade 4 side effects, if you can see, the number is really very small, essentially manageable. The most common HER2 targeted treatment related adverse event was diarrhea. Cardiotoxicity was similar in both the groups, no difference there. So to conclude, the fixed dose combination of pertuzumab and trastuzumab as a subcutaneous injection is non-inferior to intravenous pertuzumab plus trastuzumab. The pathological complete response rate and safety profiles are identical and well comparable. The follow-up is ongoing for long-term outcomes, including efficacy and long-term safety. That would be very interesting as to how this combination works out in the long run. But I definitely appreciate the science behind it, the scientific data, the concept, and the design appears very robust. So definitely encouraging combination, especially for patients who are planning to receive it for long term, like patients in metastatic breast cancer, where they usually receive this therapy till progression or till troublesome toxicity. So for this group of patients, this fixed dose combination definitely sounds a great idea. The only problem is subcutaneous trastuzumab, at least in India, has had very few takers. The approval of insurance companies can be a major hassle. So right now, till this problem gets sorted out, I don't see any way we can start using this combination. But scientifically speaking, this sounds definitely a great idea. Thank you.